Hi, welcome to the overview of Medicare for people living with ALS. Before we begin our webinar today, I want you to know that you're muted and not on camera, so please relax and enjoy your presentation, which will last for about an hour. You'll notice a chat box to the right of your screen and enter the questions in the session after the presentation. Lastly, this program is being recorded and will be available to view on our website, and we'll also have Kathleen's slides. So let's get started. I'm Lauren Webb, the Director of Support Services and Education at the Les Turner ALS Foundation. Thank you for joining our ALS Learning Series with Kathleen Holt. Before I formally introduce you to the speaker, I would like to tell you a little bit about our foundation and our sponsors. The ALS Learning Series is made possible because of the Gilbert and Jacqueline Fern Foundation and our industry partners, Cytokinetics and Mitsubishi Tanabe Pharma America. We are leaders in comprehensive personalized ALS care and research. We realize that people living with ALS may feel overwhelmed and unsure of what questions to ask and what to do next. Our support services team is comprised of knowledgeable and compassionate nurses and social workers with many years of experience guiding people and their families living with ALS. We offer a variety of services, including care visits by ALS support coordinators and need-based grants and connecting people with community resources. At the Lois and Solia at the Les Turner ALS Center at Northwestern Medicine, we offer access to enrollment in clinical trials and a multidisciplinary team to provide support. We know that making decisions about ALS care can be overwhelming, but we're here to help. Les Turner ALS Foundation has resources to help you learn more about your options. Please visit lesturners.org/resources for more information. Now I'm pleased to introduce to you Kathleen Holt. She joined the Center for Medicare Advocacy in 2014. She's the Associate Director and Attorney. In addition to her law practice, she's experienced in hospital administration with an MBA in healthcare management. After obtaining her law degree, Kathy became a Special Assistant U.S. Attorney for Social Security and the U.S. Department of Health and Human Services in Seattle. Following the birth of her profoundly disabled youngest child, she founded the Seattle area law practice advocating for those with special needs and older adults. After the ALS diagnosis of a close friend in 1991, Kathleen served as president of the board of both the ALS Association Evergreen chapter in Washington, Idaho, Montana, and Alaska, and subsequently the Connecticut chapter. She was also the National ALS Association trustee. She currently serves on the board of Team Gleason, Yale New Haven Health Systems, and Lawrence Memorial Hospital, and the Connecticut Teachers Retirement Board, and the Mansfield, Connecticut Housing Authority. So please join me in welcoming Kathy today.
Thank you so much, Lauren. I'm going to share my screen and then we'll be off because we have a lot of material to discuss today. Thank you. And I want to make sure that I'm not looking at me. Just give me one quick second here so I can navigate the slides properly. Okay. For those of you who don't know about my organization, the Center for Medicare Advocacy is a nonprofit, nonpartisan law organization. We were founded in 1986. And our mission is to advance health equity, access to comprehensive Medicare and quality health care. We are based in Connecticut and Washington, D.C., and we have additional attorneys in different parts of the country. As I mentioned, our main goal is to provide education, legal analysis, writing, assistance, and advocacy to help individuals to have confidence in their Medicare benefits and understand them and be able to advocate for them. We work for systemic change in addition to our individual policy. We do systemic policy, looking to make bigger changes to the system when it's not working properly. And we do Medicare coverage work, Medicare appeals, and work with states to make sure that Medicare is paying when it should and that Medicaid is always the payer of last resort. So that's my organization. Today, in an hour, and usually this is something that, I could spend, we literally do trainings that are 18 hours long. So I'm going to give the highlights, if you will, of a lot of what makes up Medicare and what may be important to folks who are living with ALS. So the Medicare overview: what is Medicare? What does it mean? Where did it come from? What do we do about it? Medicare premiums and costs, and looking at tips and assistance to pay for Medicare costs. When people need to transition to Medicare, if they have other types of insurance and they're coming on to Medicare, as well as coordinating with other types of insurance. And then looking at how do you make a choice when you're in Medicare as to whether or not you will be in the traditional public Medicare program, or if a Medicare Advantage plan is the best opportunity for you to get the most out of your Medicare. We got about 20 some odd questions in prior to the presentation today, and so I'm going to go through those very quickly when I finish my presentation, kind of as a lightning round, so we can have as many other live questions as possible. But I do want to be able to address as many of the questions that have come in. I know some of them are more general that would apply to a lot of people, and some of them are less so, but we'll do the best we can in the time that we have. So thank you for having me. Looking at a Medicare overview. So Medicare is national health insurance, started about 55 years ago. And people usually qualify for Medicare based on paying into the Social Security system, not based on low income, which is typically where people get Medicaid and Medicare confused. So Medicare is the national federal health program. Medicaid is based on income, and it is administered by states. So every state may have a different type of Medicaid program. Medicare covers people who are 65 and over, certain people with disabilities, and end-stage renal disease. And these are the typical services that Medicare covers: hospital, nursing home, home health, doctors, durable medical equipment. And people can get Medicare through private Medicare Advantage plans. We're going to look at the differences, the advantages and the disadvantages to all of the options that people have in front of them when they qualify for Medicare. And Medicare should cover Medicare Advantage. These private plans should cover at least as much as traditional Medicare and follow the exact same coverage rules. So Medicare is an insurance model, which means that it covers some of the cost of some health care. And the general framework of when Medicare covers is when the services are reasonable and necessary for an illness or injury to diagnose, to treat, or to rehabilitate. There's limited preventive coverage, and there are copays, coinsurance, and deductibles in addition to the premiums that you would pay. So Medicare is, in its own way, very much like commercial insurance. So to give you a quick overview of Medicare, there are considered to be 4 parts of Medicare. Interestingly, they are not all parts of a whole, like you would think of, parts of a pie. They are different, and I'll explain how that works. So the original Medicare, which started in 1965 and was the only Medicare that was offered to individuals for upwards of 30 years, was Medicare Parts A and Part B. So Part A is essentially inpatient insurance. It includes hospitals, skilled nursing facilities, and can include home health care. It's the major parts of Medicare, the major services that are offered by Medicare. And the important thing to know about Medicare Part A is then when we pay Medicare taxes into the Medicare system, that allows us to have premium-free Medicare Part A when we reach eligibility for the program. So essentially, let's think of Part A of Medicare as inpatient insurance, and Part B is called medical insurance, but it's what I would consider the a la carte services, whereas Part A If you go to the hospital, they're paid on a bundled payment. It's all inclusive. It includes your drugs, your room and board, your food, everything you get in the hospital. But under Part B, this a la carte system, if you will, that's where you have your physician charges, your therapy charges, your durable medical equipment. Those are paid through Medicare Part B. And if you're in the traditional program, there's typically a 20% coinsurance that's attached to Medicare Part B when you go to the doctor or you go to, or you get some equipment. And then in the late 1990s, the Medicare Advantage program came into being. And this is where private insurers said, hey, we kind of like this idea of taking Medicare risk for the people that qualify. So that became known as Medicare Part C. And when I said it's not all parts of a whole, you can choose when you become Medicare eligible if you're going to get your services through traditional Medicare, public Medicare, which is Medicare Parts A and B, or if you're going to get your services through Medicare Part C, which is the private Medicare Advantage plans, the private insurance companies. And just to make things more complicated, you can get a Medicare Advantage plan, a private managed care plan that is all inclusive of medications, or you can get it without drug coverage. And people who typically will do that are folks that have access to prescription drug coverage through another avenue, like the Veterans Administration, or through past employer plans. So then there's finally, that came in about 2006, the Part D prescription drug program. And that is for medications, Part D. So these are all the parts of Medicare. While I'm still on this slide, let me go back up to under Part B of Medicare, where it says supplemental policies. So if you decide you're going to go the route of traditional Medicare and you have Parts A and B, and then you think, I'd really like to get some coverage for those co-insurances and co-payments and deductibles that I'm going to be responsible for. If I need a wheelchair, that 20% that I'm going to have to pay. So you might pick up what's called a Medigap policy or a supplemental policy to cover the gaps that Medicare doesn't cover. There's also something called the Medicare Savings Program, very important program. Not enough people who qualify for it even know about it. So I'm going to spend a little time in the program talking about that, because it will also help you to pay for the costs of Medicare. Or some people have retirement plans, or when they've left their employer, if they are disabled, they have some coverage that they take with them. The supplements will pay for those gaps in Medicare, pay for those co-insurances, deductibles, and co-pays. If you instead choose to get your Medicare through a Part C plan, if you remember from the previous slide, Part C of Medicare must cover everything that Part A and Part B cover. That's a requirement. That's the base. They can add additional, and sometimes they have additional services like some dental or gym memberships or a few rather low value items, but they can cover those as well. So those are all the parts of Medicare. Now we're going to look at Medicare premiums and costs. And the reason that I put this slide kind of where it is instead of for coverage is because I think it gives you a sense of where costs are in Medicare and what you have to pay for. And that makes a big difference to how you're going to end up choosing what you can afford when it comes to all the cost assistance you can get, and then choosing the right Medicare that's right for you. So Medicare premiums, as I mentioned, under Medicare Part A, if you have paid into the Social Security and or Medicare system, you've paid Medicare taxes, then you're typically entitled to premium-free Medicare Part A. About 90% of people who are on Medicare receive premium-free. If you've never paid into the Medicare system, but you may be eligible for it, you would be known as what's called a voluntary enrollee, where you would pay into Medicare Part A. We're going to look at that. And then the Medicare Part B premiums. Most people are in the standard range, which for this year is a little over $170 a month. But there are people who have greater income. And in this case, for Medicare, if you have income that's over $91,000 a year as an individual, you will have to pay a premium on the premium in order to get Medicare. But there are ways to reduce that amount as well that we'll talk about. And then there are premiums for Medicare Part C and D. So this is just to give you an overview of what we're going to look at next, and also finally to look at the Medicaps when it comes to the costs of Medicare and premiums. So Medicare Part A premiums, anytime you enroll in Medicare, you're eligible for Medicare, that is the purview, if you will, of the Social Security Administration. Social Security is the gatekeeper for Medicare. So that's why you will see, and I have another slide a little while later that will talk about when you can tell when you need to contact Social Security and when you need to contact Medicare. Again, most beneficiaries don't have to pay premiums for Part A, and the rule is that if you have paid into the system any time in your lifetime for an aggregate of 10 years, then you will likely qualify for premium-free Medicare Part A. I mentioned that if that's not the case, then you can become a voluntary enrollee. Voluntary enrollees have less than that 10 years or 40 quarters of coverage. And the other way that you could pay into premiums is if you are a permanent legal resident. So United States citizens, yes, you can become a voluntary enrollee, but also permanent legal residents. And that is defined as someone who has lived in the United States for at least 5 years in a row immediately before qualifying by being age 65 or older or becoming disabled. So then we have spousal work history. This becomes a little bit tricky with when you're under the age of 65, but the general rules for qualifying on your spouse's record, you have to be married for at least a year or divorced and married for at least 10 years, remaining single, widowed, married for at least 9 months. And then if you have a partnership, same-sex marriage, then that also counts for spousal work history. There's also qualifications for children who are disabled prior to age 22 to receive benefits on the work record. So we'll look at that a little bit more closely when it comes to people with ALS, and particularly if you're under the age of 65, because the rules typically are that you can only do a spousal, be on a spousal record if you're over the age of 60 as a widow or widower, I'm sorry, over the age of 50 as a widow or widower. And so there are very specific rules. And if you kind of are trying to figure out if you fit into that, there's a lot of information on the Social Security website, but it's always good to call Social Security directly and have them look at your earnings record and your spouse's record to see where you would fit into that. The premiums, as you can see, if you're a voluntary enrollee, having earned less than 40 quarters, can be quite substantial, of $274 a month, or if you have less than 29 quarters, $500 a month. A lot of states have what they call buy-in programs. So rather than put a person on Medicaid if they haven't worked long enough and haven't gotten the quarters, if you do qualify for Medicaid, then typically, again, depending on the state, they may buy into Medicare. They may pay these premiums on your behalf because it's better for the program, the Medicaid program, if you're getting Medicare services rather than having the state pay out of the state pocket for your care. Okay, as I mentioned, the standard monthly premium for those whose income is less than $91,000 is about $170 this year. I won't go into the hold harmless because it's a rabbit hole that basically says if your Social Security goes up, say $30 next year, but your Medicare premiums go up $50 next year, not that they're going to, but then you would be held harmless, and your Medicare premium would only go as high as the increase in your Social Security. Given everything that's happening with the economy, we hope that actually the word is that the Medicare premiums will be coming down because they went up way too high this year. It's another story. Sorry, I can go off on tangents. So there is something that I mentioned. If you're making more than $91,000 a year, people with higher incomes would have a premium increase. You can get that premium increase decreased fairly easily by filing what is known as a major life-changing event form. So typically when people are working, they have a much higher income, and then it goes down when they stop working because of a disability like ALS. And so what would happen is Social Security will look at the tax return that was filed from 2 years previously. That's how they calculate this income-related monthly adjustment amount. If you file a major life-changing event form, one-page form that says my income dropped from this to this, they will look at the most recent tax return that you filed, and you can get a significant reduction in your Medicare premiums by filing that major life-changing event form. And I have a link on the slides for how you can get to that. So Medicare Advantage premiums. So we talked about Medicare Part A premiums, Medicare Part B premiums. Medicare Advantage premiums for 2022 vary significantly. It can be several $100s a month. It can be a subsidization of that Medicare Part B premium. I can't emphasize enough where people go wrong with Medicare mostly is that this is notification. People will have a problem with Medicare Part B. They will stop paying the Medicare Part B premium because they think, oh, I've joined a Medicare Advantage plan. I'm not in Medicare Part B, so I'm not going to pay the premium. You have to pay Medicare Part B premium in order to elect a Medicare Advantage plan. So it's maybe counterintuitive, but you have to be enrolled in Part B in order to choose a Medicare Advantage plan. So you have to continue to pay, everyone pays the Medicare Part B premium, whether you choose public traditional Medicare or you choose a Medicare Advantage plan. Okay, so then there are Medicare premiums in addition to the Medicare Advantage plans, Medicare Part D, the prescription drug plans, and the Medigap supplement plans. And here is a link to a tool that we use all the time. And this is called the Plan Finder tool. So you can go onto that link. It's at medicare.gov. And you can even just put in Plan Finder tool in the search engine, and it will bring up this window where you can put in your zip code, and then you can compare all of the Medicare Advantage plans that serve that zip code, all of the Medicare Part D prescription drug plans. We were looking at one last week where we put in all of the individuals' medications, and when it showed the premiums and the out-of-pocket costs for the different drug plans. In the same town, there was a Walgreens that had annual costs of $1,500 for the plan, next to a CVS that had that it was less than $50 for the entire year. So you can really get a lot of information from this Medicare Plan Finder tool to help you with both looking at Medicare Advantage plans, standalone prescription drug plans that you would get if you joined traditional Medicare, and a Medigap plan that again will fill the gaps of what traditional Medicare doesn't cover. So this is a slide. I'm not going to spend a lot of time on this. It just gives you a sense of what the costs are in Medicare in 2022. There's a hospital deductible, there's co-payments once you've been in the hospital for more than 60 days. There is a co-payment in a skilled nursing facility if you, again, have been there more than 3 weeks, Part B deductible, and that co-insurance that I mentioned. With Medicare Advantage plan, these figures are for traditional Medicare if you join traditional Medicare. If instead you join a Medicare Advantage plan, a private plan, cost sharing varies per plan. So for instance, in traditional Medicare, there is no coinsurance and no deductible for, or no copayments for home health care. I've seen Medicare Advantage plans that have as much as 50% coinsurance for home health care. So this is, again, really important that you start to think about, well, what services am I going to use? Do I think I'm going to use? I always say to people, you don't have a crystal ball, but I will also say that when you have ALS, you do, in a way, have that crystal ball. You know what you're looking at. And I'll talk quite a bit more about my suggestions for you about how you approach what do you do with this program that's incredibly complicated, and how do you make the right choice? So, assistance for individuals to pay for Medicare. There's something called the Medicare Savings Program, as I mentioned earlier. It's very, very much underused. People don't know that it exists. And so, yes, it helps lower income people pay for all or some of Medicare costs, but eligibility is based on income and, in 40 states, assets. We are moving more and more towards more states who do not count individuals' assets for resources. So Medicare Savings Program income and asset criteria will vary by state, and they are administered by the state Medicaid agencies. But don't let that put you off. If you don't qualify for Medicaid, does not mean that you would not qualify for a Medicare savings program to help with the Medicare premiums and out-of-pocket costs. So we already looked at a slide of most of these costs, but these are examples of what the Medicare savings programs may cover. Both the out-of-pocket costs, as well as you can see, these programs can pick up that $170 a month monthly premium, which is great. Here's just an illustration of how stunning it is that these programs are so underutilized. There are 3 qualification programs in the Medicare savings programs, which, again, I'll talk a little bit about what those qualifications are. But you can see the QI program on the bars that are on the far right. Only 15% of people are enrolled. 85% are eligible but not enrolled. That amount, typically, depending on the state, we'll look at some of those qualification numbers. But again, it's really important to get screened. The screening for these programs is very quick, and I'll let you know how you can do those screenings. So here's a snapshot, if you will, because I know we have people from across the country on the program today, of financial eligibility. Most states do use the federal guidelines, which is from 100% to 135% of the federal poverty level. And currently that is about $1,100 a month for a single, or $1,500 a month for a couple, but that's 100%. It can go up to 135. 8 states have much higher income guidelines than that. And 37 states use the federal guidelines for assets, which, if you needed a new roof on your house, that's not going to even cover it. So those asset tests are really low in those particular states. 3 states have a higher asset test, and then there are 10 states that have no asset test whatsoever. California is in this process where they're changing to become a no asset test state. These are just some examples, if you are subject to assets and resources, of what may be excluded from that $8,400 that I just showed you. So this is an important slide, and I would say to you, this is my favorite resource from the National Coalition on Aging. They are a fabulous organization, and here's a link here. So you can look up your individual states and you can find out if you might qualify, or you can contact this SHIP, which is the State Health Insurance Program. These are folks that are highly trained on Medicare. This is a free service that's paid for largely through the Administration on Community Living nationally. And these are folks that if you find out which SHIP serves your state, and when you do that, they will do a complete assessment on what Medicare you should choose. Do you qualify for any of these cost assistance programs? So again, the NCOA chart on the link up at the top will really give you a sense of each state and what the qualification criteria are for getting help with Medicare assistance payment. And then the SHIP program, which is, I can't say enough, we do all the training for a number of states, but these are folks that are really able to help look in depth at individualized assessments for people. And here again is the eligibility for the National Council on Aging. Some other resources that you might find for payment assistance: there is a low income subsidy that helps to pay for medications and premiums for medications. As I mentioned, there are buy-ins for people who would have to pay for premiums for Medicare Part A and B, that through the Medicare Savings Program, the states will do that for you if you are a Medicaid recipient as a buy-in for those states. And then the State Health Insurance Program, again, here's a link because it's a fabulous organization, and every state has a number of them. Okay, so now I'm going to turn to transitioning onto Medicare and coordinating of Medicare with other insurance. This link here is simply, when do I contact Social Security? When do I contact Medicare? So just generally, this is a great one-page kind of checklist of, do I call Social Security or do I call Medicare? Generally, you call Social Security for eligibility or enrollment, initial enrollment. You call Social Security if you have been assessed any penalties. Most of the time you pay your premiums to Social Security, or comes out of your Social Security check. So if you have any issues with that, you would call Social Security. Medicare is where you typically call for coverage issues. And if you have to pay those income-related adjustment payments, this extra more, if you're making more than $91,000 a year, that is actually handled through Medicare. So there's different kind of quirks about the rules of when you contact Social Security or Medicare, but this one-page document is really, really helpful about just knowing right off the bat, you're not, taking yourself off on a left turn that would end up being very frustrating. So eligibility, there are 3 different ways to be eligible or to qualify for Medicare. Aging into Medicare, someone who is disabled, so you're under 65, over 18, after a 5-month waiting period, and then you have a 24-month waiting period. Of course, the great news, if there's any good news for people with ALS, is that the waiting periods are waived with ALS. Another way to qualify for Medicare is through end-stage renal disease. So when you age into Medicare, and I can imagine there could be some circumstances when you have ALS that you're either turning age 65 and you're still working, you haven't stopped working yet, you haven't applied for disability. So just know that if you are aging into Medicare around this age 65, there is a requirement to sign up for Medicare typically 3 months before you turn 65, the month of your birthday, or 3 months after. So that's like a 7-month period that hugs your birthday month. And that is typically how you would get in if you were over 65 or over. If, however, you're applying because you're on disability, once you file your application for disability benefits, you should receive, as having ALS, and I'm very specific about that because I did have a question about someone who might have PLS. The law is really clear and seemingly narrow as far as the waiver to only apply to people who have ALS. So once you file that disability application and it's approved, it should automatically trigger the Medicare part of the benefit. You will be typically automatically signed up for Medicare Part A and B, and if you don't want Medicare B because you have other types of insurance, which we'll talk about, then you can decline to have those premiums taken out of your Social Security. Okay, so there are individuals who have health savings accounts. The most important part of this slide is at the bottom. This is, again, my favorite resource. If you are entangled in some way, I shouldn't say entangled, if you have a health savings account, this link, this document that is put out by the Medicare Rights Center on Medicare Interactive is the best resource that I have seen that describes how you should handle contributing into high deductible plan health savings accounts. These are people who are coming off of other insurance, they're coming on to Medicare, and you can trip yourself up if you have a health savings account. Again, we don't have a lot of time today, so I won't spend time on this, but please, if this applies to you, check out that resource in the link at the bottom. If you're in an Affordable Care Act plan and you are coming on to Medicare, let's look at some of these questions that can be really important if you're in an ACA plan. Can individuals with Medicare purchase insurance on the marketplace exchange? So these are folks who maybe you have Medicare and you're like, oh, I've got a lot of things that I have to cover. I'd like to, fill in my whatever. I can't get a Medigap plan. They won't sell me one, whatever the issue may be. Can I get an ACA plan in addition to Medicare? No, because there's a prohibition on the sale and issuance of duplicate coverage. Medicare is considered coverage, ACA plan is considered coverage, so you can't have both. Can individuals who are eligible for Medicare but not signed up purchase insurance on the marketplace exchange instead? Yes, legally you can, but you could end up with Medicare penalties if you don't sign up in time. And more importantly, if Medicare is supposed to be primary, it doesn't matter. If you've got ACA coverage, you should have Medicare, but you signed up for ACA, they're only going to pay what Medicare would not pay. So be very careful about getting into a different plan when you're eligible for Medicare. If you have coverage from an individual marketplace plan and then during the year enroll in Medicare, can you keep the marketplace plan? So this is a transition, someone who's in transition. You get the notice, your Medicare is going to start July 1st, so you have the individual marketplace plan up until that time, and then it's time for you to enroll in Medicare. Can you keep the plan? Yes, you can, but again, you lose any premium tax credits and reduced cost sharing because it's considered duplicate coverage. And Medicare, as I mentioned, would be in the first payer position. They're required to pay first. So you'd be paying for a plan that would act as a supplement to Medicare. Will individuals who are enrolled in individual marketplace insurance be subject to Part B or voluntary Part A late enrollment if they delay enrollment in Medicare? Yes. So if there are penalties attached to Medicare if you don't sign up in time. We don't have enough time in this program to get into penalties and what they may mean, but you want to avoid them. So there we go. And again, this is a question about the duplicate insurance, and you can't have Medicare and an individual insurance through the marketplace exchange. So this is the best slide of this whole section to me, because if you have other types of insurance, and if you will know if you have insurance coverage through the VA, or you have insurance coverage through a family member who is still working, and you have Medicare for yourself, you will want to call the Benefits Coordination and Recovery Center, the BCRC. This is also known as the Coordination of Benefits Coordinator for Medicare. You want to make sure that they know all the types of coverage, and it could even be like a workers' compensation settlement, any types of insurance that may be responsible. And the reason why this slide is so important is you don't want to have to unravel or untangle a problem if Medicare pays and then it turns out they find, oh, we have this other insurance, they should have paid first, or this one should have paid first. So it's just Medicare will help you to bill in the right order to the right payer. So if you have multiple types of insurance, whether again through the VA, through TRICARE for Life, that will be important to understand who pays first. Here's a good chart. Again, I'm sorry, a little busy, for different types of payers. So if you have Medicare and Medicaid, you're considered duly eligible for those programs. Medicare will always pay first. Medicaid is known as the payer of last resort. And then on the chart, as you go down, you can see the next two categories are someone who is age 65 or over, someone who's under age 65, covered by a group health plan. You can tell, so you can have a family member who's working and you're kind of on their plan. It's just good to kind of work through this chart, put your own circumstances over the top of these different categories, if you will. If Medicare is the payer, is the first payer, they're the ones who are in the first payer position, you can never delay signing up for Medicare. If, however, Medicare is in that second position, so let's see, under age 65, you have coverage from a group health plan because someone is active, a family member is actively working at a company that has 100 or more employees. That means that that group health plan is the first payer. You don't even have to join Medicare right away because Medicare is the second payer. You can do any number of different kind of coordination of that, but wherever you see Medicare in this chart that it says Medicare is first as a payer, do not delay signing up for Medicare when you're eligible for it. Just an interesting, there are different rules that apply. Coverage rules will never differ. Doesn't matter if you're under 65 or over 65. Doesn't matter who you are. Coverage rules are always the same. What does change is kind of this eligibility criteria, not eligibility, enrollment criteria when it comes to things like paying first. So the rules, if you're age 65 and over, you can be considered under a group health plan of an individual only if it's you or your spouse that's still working. Under 65, it's a broader category. So a group health plan coverage as an employee or a family member. So it doesn't have to be just a spouse. You could be under a grandparent, a grandchild, whatever the insurance covers. If you're under it, you will know. So, but just understand that for Medicare purposes and who pays first, if you're disabled and on Medicare, you have kind of more options as far as coverage to delay the Medicare enrollment if you want to. Just another couple that are more broadly available for people who are on Medicare. A number of people COBRA is the continuation of employer insurance. And typically, when you're eligible for Medicare, Medicare will pay first, COBRA pays second. So my caution, because people stumble over COBRA more than any other type of service, having COBRA insurance, having this continuation once you stop working, only protects you for 8 months in Medicare. Otherwise, you have to get on to Medicare as soon as possible because it's not considered duplicate cover. I mean, it's not considered creditable coverage for Medicare. It doesn't allow you to avoid penalties if you take COBRA. A lot of people take COBRA because they're comfortable with the insurance. They had it when they were working. Now they've stopped working. They have the ability to get that insurance. I would say be very, very, very careful about taking COBRA instead of Medicare. If you're a veteran with veterans benefits and you go to a VA care provider, you can, the veteran coverage will typically cover the VA, anything you do in a VA facility. If you go to a non-VA provider, Medicare typically covers. And the same thing you will see if you have insurance through active military or the TRICARE or TRICARE for Life. If you go to a federal provider or hospital, TRICARE pays first, Medicare second. And if you go to a non-military hospital or federal or non-federal provider, then Medicare will pay primary. Okay, so this is, I think, my last spot, and I really want to get into questions. But there's so much that we could talk about choosing between traditional Medicare and a Medicare Advantage plan. As I mentioned, Medicare Advantage plans are just another way to get Medicare benefits. The plans contract with Medicare to administer the program, so there's an oversight capacity that Medicare has over these private plans. The plans combine Medicare Part A and Part B coverage and often the prescription drug coverage. Remember, they have the same coverage rules as traditional Medicare. They may have different payment options. Like I said, some will charge up to 50% of a coinsurance for home health care. So they can kind of alter the payment. They cannot alter the coverage. And Medicare Advantage plans are not supplemental insurance. So you can't get regular Medicare and a Medicare Advantage plan. You have to choose between those two. You cannot get a Medigap or a supplement policy with a Medicare Advantage plan. So while there's an out-of-pocket cap on most Medicare Advantage plans that can range anywhere from about $3,000 a year to the typical out-of-pocket is closer to $7,000 a year, deductibles, co-payments, and coinsurance are paid out of pocket. You cannot get a supplement plan, unless, of course, you have an outside supplement plan like a retiree insurance or something like that. So pros and cons, there are pros and cons. Enrollment in Medicare Advantage plans should be, you need to figure out exactly what's important to you. And I have a list of the things that we find that are important. This is a chart that was provided through the Kaiser Family Foundation. And this is not Kaiser Healthcare. This is a different arm that does a lot of research, and they really are values people. So advantages to Medicare Advantage plans: one-stop shopping. You can get it all kind of like in one swell swoop. You get all your coverage. You don't have to get like a separate Part D plan and other and a Medigap plan. The premiums can be lower for a Medicare Advantage plan, but again, it's important if you qualify for the Medicare Savings Program and you can get help getting those premiums paid. That's a big consideration as to whether or not you should get your coverage through traditional Medicare or Medicare Advantage plan. Plans will offer additional benefits such as dental. They have those out-of-pocket limits that I mentioned. Potential for better coordinated care. I don't see it, but this is Kaiser. So I wanted to be at least a little unbiased and show you what others were saying. Potential disadvantages: there's a limited provider network. So when you join a Medicare Advantage plan, you typically can't go to doctors outside that network. There's a potential for out-of-pocket costs that again could be higher. You certainly get more utilization review, more prior authorization requests than in traditional Medicare, and it's difficult to swap back to traditional Medicare. If you first join a Medicare Advantage plan, you may be locked out of the Medigap supplement plans. So again, one of the things that I want to point out on this slide that I think is really important, particularly if you're living with ALS, is that you need to balance kind of the premium costs of everything as well as the value of the extra benefits. because depending on what services you think you're going to need the most significantly, those are what you really want to focus on, making sure that you get as much coverage for those services as possible. Medicare Advantage plans have, you can see a very high coverage for things like eyeglasses, fitness, telehealth, hearing, and dental. If you are in one of these plans, check again the value of it, because we've seen a number of these types of plans that, yes, they may offer dental, but it may be like $100 a year, or you have to go to one of 3 providers. So you just be careful about that. Nearly all Medicare Advantage enrollees are in plans that require some prior authorization, and I have seen things denied for the most crazy reasons. There was just a recent report that came out from the Office of Inspector General that said that 1 in 5 Medicare Advantage enrollees are I'm gonna say inadequately, but they are inadequately denied prior authorization when they qualify for services. So again, sometimes it's a matter of just, being an advocate and fighting for something. But I know when you're living with ALS, it's hard to find the energy to fight battles that you really don't have to. Okay, so this is a roadmap, and again, I realize my time is very limited, so I'm just going to leave this here with you to be able to use, and I know you're going to have access to all of these slides, because I do want to get to questions and the narrowing of the options. We've come up with 10 kind of ways for you to think about, just questions for you to think about that will help you determine whether you should be in traditional Medicare or Medicare Advantage plan. I think if you, again, can see if you qualify for payment assistance, it may make a big difference to the choice that you ultimately will make about your services. So, so think about the payment assistance part of things, and please do try to get those screenings done. They're fairly quick, and you may learn a lot of things about programs that are available to help. There's a lot of money for the from the CARES Act that was injected into the communities, and the area agencies on aging will be able to help you to locally know if you can get services and extra funding as well. Providers and facilities do you go to? Okay, my bottom line on all of these slides is to say to you, if you go to an ALS clinic, or if you have a pulmonologist or neurologist, whoever you're working with that you really feel comfortable with, I would say make an appointment with the office staff of that provider and literally say, okay, you tell me what are the best Medicare Advantage plans. Should I join traditional Medicare? What do you suggest? Because I can guarantee you that the people who work in the business office, who process all of the claims, they see exactly what Medicare Advantage plans are very aggressive about prior authorization, what Medicare Advantage plans have utilization review that say, oh, the doctor ordered 7 therapy visits, oh, I'm going to cut that down to 3. Providers, not the providers themselves, but the business office has a lot of advice to provide. I work with one particular ALS clinic who together we have just worked on the local options that are available to people with Medicare. And every September, right before the Medicare open enrollment that happens on an annual basis, they send out a letter and they say, no offense, but avoid these Medicare Advantage plans. These are good ones. And it really is because you're getting such specialized services, and you need the nutritionist and the pulmonologist and all of the people that are involved, and those for someone with ALS is really important. But again, the roadmap here to give you some sense, and you'll have access to all of these slides. As I mentioned, I'm just trying to get to questions. Most Medicare Advantage plans have medical directors who make the decisions and kind of take away the ability of the treating physician to make decisions, and those are given to the medical directors. And you can, again, you want to avoid as much fighting as possible, but try to find, if you end up deciding that a Medicare Advantage plan is the best option for you to go, choose one where you feel that your doctor can have a good relationship with the medical directors of those plans, so that as much tension can be relieved in those relationships as possible. Considerations about Medicare Advantage plans, again, just for your information, after the webinar, and I know these are going to be posted as well as the recording, explaining the different types of Medicare Advantage plans. The best tool, again, is that when you go to medicare.gov and you look at the plan finder tool, you're going to see, is it an HMO? Is it a PPO? HMOs are usually less expensive, but they have very limited networks and they're really tight. They don't provide for out-of-network coverage. So be really, really careful if you join a Medicare Advantage plan with an HMO that all of your providers are within the network. And again, just more information about this. And in this summary slide, again, is everyone's circumstances is different. So bottom line, I would say to people, whatever helps you sleep best at night, all of you, whether you be a patient, a caregiver, a family member, it's so important to make the choice that works for you, and that you can navigate through. So now we're up to the questions and discussion, and I'm going to stay on past 1 o'clock. So we've got 20 some odd questions before the program. So what I wanted to do was do a really quick kind of answering of all of these questions, and then we see if we have other live questions. Okay, so I have ALS bulbar. I can't speak or advocate for myself. How do I get accommodations when communicating with Medicare? Can I authorize my caregiver to speak for me? Yes, you can formally appoint a representative through Medicare and Medicare and Social Security. You can also, we've had a lot of success with someone calling Social Security and saying, I'm calling on behalf of this individual who's sitting right next to me. And they may ask you, and you can say they're nonverbal. If there's any noise that the person can make, we've done this before where they will accept that. So you can have a conversation. And then of course there's the TTY lines. We get a lot of people that contact us through those as well. Can you get Medicare? I'm sorry, I'll let you know when it's the next question. So next question, can you get Medicare if you're not getting disability? My husband is working part-time. We need help with insurance benefits. So if you, as I mentioned, pay into Medicare through Medicare taxes, yes, if you apply. Otherwise, I would say the best opportunity, if you can find out if you can qualify through the state into one of the Medicare buy-in programs, that's an option. Or if you can't qualify for Medicare at all, I would look at plans on the Marketplace Exchange through the Affordable Care Act. Next question, does Medicare cover home health care a few hours a day? I could spend hours on talking to you about Medicare home health care. We have many, many resources and webinars on our website that address everything I could tell you that we know about Medicare home health care. So MedicareAdvocacy.org is our website. All of our resources are free. You can go, stroll through those and find out if there's how you qualify and what home health care is and what we're trying to do to make it better. Does the Medicare coverage also apply to those who have PLS? I addressed this question in the seminar that the law is specific to ALS. I'm not aware of any exceptions to that specificity, but there is a lot of knowledge on this call. And so if anyone else is aware that there's an exception, please add it to the chat and we'll make sure that that gets distributed. Next question. How is Medicare different for ALS patients versus those who simply turn 65? Some enrollment issues may differ, as I mentioned, but coverage laws are the same for everyone on Medicare. Next question, how does Medicare fund electric wheelchairs? Wheelchairs are funded through Medicare Part B. There's typically a 20% coinsurance. However, as I mentioned, Medicare Advantage plans may differ. They may have different requirements, as we're hearing more and more of these days. Again, could talk a long time about the problems with that, but we have a really good resource we developed last year. I think it's really good on our website. If you go to the website and you see topic durable medical equipment, we created a fact sheet which has a checklist of what we think you should ask suppliers when you're trying to get any kind of equipment that's Medicare covered. Next question, I'm 63, retired and have health insurance through the Affordable Care Act. Do I qualify for Medicare early with my ALS diagnosis? Okay, so some of these questions are a little bit hard to answer without knowing more of the detail. You have to not be engaged in what Medicare or Social Security terms substantial gainful activity, and then of course you have to apply for Social Security disability. So that would be kind of my answer to that question at this point. Next question, in what capacity, if any, will Medicare cover respite care? So some respite care is covered if a person elects hospice coverage. Other than that, there is no provision for respite care in Medicare. The availability of home health aides through the home health benefit requires that the individual need personal hands-on care. So some people use that benefit to do what might be helpful as respite services, but specific respite services that are called respite services are only available through the hospice benefit. Next question, is it true that a patient receiving outpatient physical therapy cannot also qualify for home physical therapy as well as outpatient? Yes, that's true. So when you're receiving home health care, the only payment that is made by Medicare is is to the home health agency. So if you're getting therapy, physical therapy, occupational therapy, speech language pathology, or nursing at home, the only payment Medicare will make for any of those services is through the home health agency. They, however, can make arrangements if they don't have a speech language pathologist. Maybe they will make arrangements, and then out of the payment the home health agency gets, they can pay for the speech language pathologist. But you can't get home health care and go to an outpatient therapist, for instance, at the same time. Oh, no, next question. Kaiser Permanente wants to move us from the government high option Medicare to their brand. Will it limit options? So I'm a little unclear what the high option Medicare is, but I would say if it's original Medicare and you move to a Medicare Advantage plan, it most certainly will limit options. If you're on traditional Medicare, you can go anywhere to any provider in the country that accepts Medicare. If you're in a Medicare Advantage plan, you have to go to the providers in that network. Next question. Using a Canadian pharmacy, I actually had somebody look this up because I wanted to be sure that Medicare does not cover out-of-country costs, but the caveat to that is I would always say, if you're unsure something is covered, check like with the Canadian pharmacy and see, maybe they have a United States license. I mean, there's always reasons that people will say, oh yeah, I can bill Medicare. So that's kind of the avenue that I would take with something like that. Next question, what is Medicare Advantage plan and what is the benefit of enrollment? So I tried to cover that, we zoomed through it, but again, please look at those resources. We could do another webinar just on that particular piece. What's considered part-time employment? So according to Social Security, you're determined to be engaged in substantial gainful activity, which is defined as earning more than $1,350 a month. So that if you were engaged in part-time employment, I would keep it below $1,350 a month. Does Medicare attach your assets to get reimbursed? No. State Medicare is not based on income. You could be Bill Gates, and you could be someone who has not a dime to their name. You get the same Medicare coverage, um, theoretically. So when you talk about assets or attachment of assets, those are in the lower income state Medicaid programs. Supplemental insurance options. I think that, I'm sorry, this is the next question. Supplemental insurance options. I think it's referring to what are the supplemental insurance options? Medigap, Medicare Savings Program, Veterans Administration, employer union plans. That would be something that I would suggest. So I'd like Kathleen to address the status, sorry, next question, of the ongoing battle to get Medicare to pay for home care for ALS patients. We are looking for cases. I'm putting myself out here because we are looking for cases to help to bolster the visibility of the problem of people not getting the services that Medicare legally covers. And everything that we do toward this activity, which may in the future include litigation on the issue as a class action lawsuit, we are looking for people to participate. But in the meantime, please watch our website for all updates on home health care and our progress on those issues. It's it's a big program. We're moving as quickly as we can, but it's hard. Next question, how to qualify for Medicaid home health care or nursing home care so as not to leave the spouse with no remaining assets. Again, not Medicare, that's Medicaid. It's a very different program and it's state specific. So I would say contact your Medicaid program in your state or the state health insurance program, even though their focus is on Medicare. They do help people to apply for and give a lot more information on Medicaid than I'm able to do. Next question. Who do we call to get these benefits? So again, we talked about Social Security handles Medicare enrollment, Medicare. If you're looking like how do I get a Medicare Advantage plan, or how do I know what to do? Again, that plan finder tool on the Medicare.gov website is a wealth of information. What about possible Medicare benefits for caregivers of PALS? So under Medicare, each individual has to meet the Medicare eligibility requirements as we discussed. And there are those spousal benefits, but again, it's a caregiver would not be considered unless it's a spouse and they fit into the criteria. I'm sorry to be the bearer of bad news. What is available financially for, next question, what is available financially for someone who hasn't worked since they were married very young and not deemed eligible? So again, I would point you to the state health insurance program. That the link is in the slides. They can do an assessment of what you might qualify for. If there's no Medicare eligibility, again, through the state health insurance programs, you can access the Area Agency on Aging for any available resources that there are resources tucked away in all kinds of places that, for instance, respite care. So you just need to contact the SHIPs and they will know what local resources are available for different programs. Next question, can Medicare assist with renting a hospital bed? So again, Medicare will pay their share to rent a hospital bed. And typically under traditional Medicare, if you rent for 13 months, it's rent to own and then you own it after 13 months. If the question is about physically assist, I was a little confused about what the person wanted to answer. If it's about physically assisting, like can Medicare assist us find a hospital bed? Medicare will be able to tell you if you call Medicare. You can either go to their website or you can call Medicare at 1-800-Medicare. They will tell you about the providers near you in your zip code. And then you will have to find a way of contacting those providers. They will go so far as to tell you which, suppliers in your area have hospital beds that are covered by Medicare. You always want to pick a supplier that accepts Medicare assignment. That includes, training, delivery, and any kind of repairs. Okay. Next question, if you don't qualify for Medicaid, and don't want to spend down your assets, how does Medicare help? So again, Medicare and Medicaid are two very separate programs, but we have a lot of information on the Medicare covered home health, including advocacy tips in a lot of the programs that we've done earlier this year. So feel free to go to our website on that. Had some questions regarding speech language pathology. Let's see. I think I'm going to, I didn't quite understand that question, so I'll go over that one. Why won't they cover a device at 100%? So Medicare has never paid more than 80%. And then if you have a supplement, then they'll pay the other 20%, but I can't say otherwise. Why does speech therapy and physical therapy come out of the same Medicare dollar bucket? So there are no longer any therapy caps. So if you qualify for therapy, aggregate claims, meaning the claims for therapy that you accrue, outpatient therapy I'm talking about here, if you accrue outpatient therapy claims above $2,150, it requires a billing code modifier. I'm not a big billing person, but I do know if you put a KX on the claim, they'll pay up to $3,000. And then once you hit that $3,000 of therapy claims, of outpatient claims, it's subject to CMS medical review. That sunsets in 2028, but look, we've got 6 more years to go until that happens. But as long as there's good documentation of why the therapy is necessary, it should overcome the CMS medical review. That's what I know. So again, I'm really sorry. It's 2:10.
Yeah, well, I have a few more questions. I mean,
Sure.
if folks can hop off if you need to. This will be recorded, and we will also post. There's a lot of really lovely comments, Kathleen, about what you have talked about. And I know this is kind of difficult, but it's a policy-oriented question. Regarding Medicare Part D, there are several drugs that either are FDA approved or pending approval. Can Medicare have any influence over prescription drug plans for formulary approval, reimbursement, and patient out-of-pocket cost?
So remember when I said that that Medicare Part C and Medicare Part D are private Medicare. So that there are some oversight functions that CMS has, but they have no influence over the FDA and what the FDA determines. There are very specific rules over whether a drug is off-label. So, there are certain things that manufacturers of drugs know that they need to do in order to make it as easy as possible for medications to be included on the formularies, which is just a fancy term for on the list of covered drugs. So if you use that plan finder tool that I talked about and you go into either a Medicare Advantage plan or a standalone prescription drug plan, you can put the name of that drug and the dose that you take, and then you can find out what formularies, what plans cover that drug. No, there's a limited amount of drugs that are required to be covered. And then there are drugs in different classes that are required to be covered. And then you can ask for an exception of the coverage. Clearly, you don't want to go into something thinking, okay, I like everything else about this plan, but it doesn't have my drugs. Maybe I'll ask for an exception. That's always a little risky. But on the other hand, this is where you really have to balance all of your needs. So you keep limiting the options that you have available to you. You certainly have more options if you choose traditional Medicare, and then all of the Part D plans that you will probably have access to. It's a test of patience, but I don't know if I answered that question, but
Yeah, I think we're all grappling in the community, trying to figure out, with the high cost of drugs and what does this mean as we add more cocktails. And what
I
is
think
this?
I would say mostly that Medicare plays a more passive role about the drugs and kind of allows the different companies who cover different drugs to develop their own coverage. And then there's hopefully enough choices of plans out there where people can find what they need. I will say, though, that if you are seeking a formulary exception, usually if there's no other drug in a class, and again, with ALS medications, and thank goodness now, who knows, we're hopeful about the oral Radicava, right? But if there's no other drugs in a class, or there's such a specific need for a drug, those formulary exceptions are not that large of a hurdle generally as say, for instance, prior authorization for services can be. So that's just our experience.
Well, thank you so much. We have loads of other questions. We'll try to address them as best we can. And
I'm happy to come back.
Actually, I didn't want to put you on the spot, but we totally want you to come back, and we would love for you to talk about home health coverage and really kind of sorting that out for folks, because this is really tricky stuff, and for folks living with ALS, this is really important, but it's overwhelming, and having some guided hands to walk through and some resources to help you is really critical. And I can't thank you enough, for all this information. And thank you again for everything you do with the community. We're extremely grateful. So thanks again, Kathleen.
Oh, thank you very much, Lauren.
So I just wanted to walk you through a little bit more about a couple things that we have that are coming up. We have complementary and alternative therapies with Dr. Tabby on July 14th. I saw this talk a few years ago. It was really great, and it's also really helpful for caregivers. I learned some really great skills myself that I put into practice in addition. And then we also have our annual symposium. It's available for in person if you're here in Chicago, and it's also available. We'll be streaming. We should have the registration link up, I don't know, probably in July for sure. So we'll have that information, and we'll share that with you. And so I just want to thank you again for participating in today's webinar. Again, thank you to Kathleen. I think that was really informative and a lot to digest, and encourage you to work with your local ALS organizations or work with the Les Turner Foundation, and we can help talk through and work through different strategies. And usually we refer to the great organizations that Kathleen mentioned. So thank you for spending time with us today. We look forward to having you join us in our next webinar. Please take a moment to fill out our survey that you'll receive immediately after the webinar concludes. Your feedback's super helpful, and that's how we make decisions about the webinars that we offer. So thanks to everyone for joining, and we look forward to seeing you next month.